Dr. Pradeep as our next speaker. He is from Biocon Bristol Myers Squibb Research and Development Center, Bengaluru.
Good morning, everyone. I am a oncopathologist working for Biocon Bristol Myers Squibb. Is a US-based pharma company. So today I'll be presenting some interesting topic. So as you know, this is the era of precision medicine. So the question is, does the current diagnostic cater to the need of precision medicine? The answer is not at 100%. So imagine a world make of and the unique microenvironment that surround the tumor. Then the tumor can be, then the treatment can be more precise than following or any other textbook or trying on some trial and error method. So I'll today walk you through some newer approach to treat the cancer. That is a multimodal diagnostic approach where we can combine tumor microenvironment understanding as well as pathology, genomics, and artificial intelligence. So the case start with, this is a case that date back to 2019 when I was working in Fortis Cancer Institute. So here the case is, this is a 42-year female presented with tumor mass. So this has been reported and diagnosed elsewhere in some other peripheral center. So I got this case as for a second opinion as per the medical oncologist. So he told, Dr. Pradeep, can you give your opinion why this cancer, this cancer is, and various kind of immune cells, lymphocyte, M1, M2 macrophages, your dendritic cells, and they used to cross talk in each other in a exocrine or autocrine or varrocrine method in a manner of the cytokines and chemokines which are embedded in the exosomes. So that's how the tumor microenvironment works. So the question about is how to target tumor microenvironment. Is there any strategy we can target the tumor microenvironment? The answer is yes. There are multiple ways we can target neovascularizations, and as well as we can reverse the hypoxia, as well as I can target the cancerous fibroblast. And there are multiple ways, as you can see over here. So pertaining to this topic, I'll be focusing most on the tumor neovascularizations as well as the hypoxia. As you know, the many tumor, they are inherently neovascularized, and some of the tumor, as they upstage, they are neovascularized. So as you can see here, hepatocellular cancer, if you see any report of hepatocellular cancer, if you say any histopathology report, they used to mention that there is extensive sinusoidal capillaries, which has been highlighted by your study. Who has been highlighted by your CD34 staining. So what does that means? Means that is extensive proliferation of blood vessels. And if you see your CT contrast report, you'll find there is, they mention about there is early washout in the venous phase. That is nothing but they pointing out that the tumor is highly neovascularized. Same thing applies to the high-grade serous carcinoma when there is upstaging. They usually harbor high densities of CD34 positive blood vessels. Here you can see in these images. So these tumor, they are not initially neovascularized. As they upstage, they get neovascularized. So the question over here is, what is the triggering factor for that? What is causing neovascularizations? So if you see these articles, what you're saying, as the tumor proliferate fast, the microenvironment get hypoxic. Once there is a hypoxia, then there is stabilization of HIF1 alpha. So this HIF1 alpha, what it does, it activate multiple downstream proteins like your VEGF-A, your GLUT1, and your common antigen proteins. So this VEGF-A, what it causes extensive endothelial proliferations. And these endothelial proliferations is not in a synchronized way. So you will find lots of chaotic vessels and leaky vessels. What it does, the purpose here is to give the tumor good amount of flow and oxygenation, but it's not serving that purpose. So ultimately, tumor go for a vicious cycles of hypoxia. So ultimately, that hypoxia leads to the change in tumor metabolism, that is aerobic glycolysis, leads to huge amount of LDS productions. These LDS ultimately leads to lots of H+1 generations, and this H+ coming to the tumor microenvironment, causing the microenvironment acidic. So once there is an acidic microenvironment, So neither your chemotherapy drug penetrate and act on the tumor, nor your T cells act on the tumor cells. So it is kind of a immunosuppressive microenvironment. So the question over here is, what is the solution for that? The solution is we have to normalize this abnormal vessel by giving anti-VEGF therapy. Once you give anti-VEGF therapy, what happens? The immunosuppressive microenvironment is tilted towards the immunosupportive microenvironment. How this happen? By there is a good amount of erythrocytic coveraging, and your hypoxia get improved, your perfusion gets improved, your all the suppressor immune cells get down, such that the immunosuppressive microenvironment become supportive microenvironment. So this is the window period where you can give your immunotherapy as well as your chemotherapy. So coming back to our original case, so actually the diagnosis was correct, but it is incomplete. Actual diagnosis is high-grade serous carcinoma set pattern. So this is a typical pattern that harbor some typical morphology feature like translational kind of arrangement. You'll see high NC ratio, lots of tumor-influenced lymphocyte in the stroma as well as in the intraepithelial component. So usually this type of cancer, this pattern of cancer of high-grade serous carcinoma harbor BRCA1 gene mutations. What you did, we sent FFP block as well as your blood sample for BRCA1 gene mutations. Only the FFP sample shows the BRCA1 gene mutation. So what it says that there is only somatic mutations. So next question is, what does BRCA does? So the function of BRCA is it is a double-stranded DNA repair gene. Once that is defective, so what happens? There is lots of accumulation of defective DNA proteins, mutations. These mutations produce lots of new antigens. These new antigens taken by MST class 1 and exposed on the surface. That's drag lots of T cells to the tumor microenvironment, making the tumor immunological hot. As you can see over here, there is lots of intraepithelial lymphocytes as well as intratumoral lymphocytes. So that is why this tumor is immunologically hot. So next question is, what is the standard of care? Usually the clinician add PARP inhibitor in these cases. The question over here is can you add immunotherapy along with standard of care therapy? So for that, we need to understand which are the tumor resistant to immunotherapy and which are the tumor sensitive to immunotherapy. So if you see the tumor having inherent resistance to immunotherapy, you find all the traits like high Treg populations, high MDSC populations, or VEGF expression is very high. You can see there is IDO and adenosine activities. So on the other way around, if you see the tumor having high PD-L1 expressions or high tumor mutation burden or high TLS densities, these tumors are usually they're sensitive to IO therapy. So with this understanding, what we did, we sent the sample for PD-L1 ISC testing, which the score came out to be less than 5%. So this is the combined positive score. So this is not a great score to start any immunotherapy. So I can't convince my medical oncologist you can start IO therapy with this score. So what we did, we advised one more test, that is tumor mutation burden. So here the tumor mutation burden came out to be more than 50 mutations per megabase. This is a great score. And if you see this paper, they are telling that there is not a very linear correlation between PD-L1 and tumor mutation burden. That means there are cases where the TMB might be high, the PD-L1 score might be low. So, so that is vice versa. So you cannot depend upon only one test to decide whether the IO therapy should be given or not. So after that, we advise one more test, that is ex vivo culture, where you we take fresh tumor tissue and add the intended drug, that is nivolumab, and a control arm. As you can see, the nivolumab arm, there is massive influx of CD8 T cells. It is highlighted by this fluorescent staining in the intraepithelial component. So what is after adding this nivolumab, the activated T cell population migrate from the stroma to the intraepithelial component. So what this means the CD8 T cells, once is infiltrated to the tumor intraepithelial region, these are activated T cells. They secrete porphyrin and granzyme. They started killing the tumor cells. So as you can see, once the tumor cell killing happens, your cleaved caspase, that IC score goes off and your proliferation goes down drastically. And also you send for nanostring analysis where we check for tumor inflammation signature. You can see the tumor inflammation signature here you have used the panel is IO 360. So it will give you a 360 view of your inflammatory gene signature. So all these things pointing towards one thing, that the tumor is inflamed, and the CD8 T cell activated, they have started killing the tumor cells. Simultaneously, we also pull out some the articles which depict that the use of pembro in the high-grade serous cancer in the keynote 2 study from the Merck. So all this evidence, we could convince the medical oncologist, you can start giving bevacizumab. After that, you can start giving IO therapy along with standard therapy. So after 6 to 7 months, I got a call from the medical oncologist that, Pradeep, there is a massive reduction of tumor size in the hepatic mets. The size has gone down from 5.4 centimeter to 2.7 centimeter, and all the smaller mets has vanished almost. So this is a massive response. And the same thing you can see in the slides, in the form of IRPRC. This is nothing, it is a science of immuno-related pathology response criteria. Here you see the response in the form of immunoactivations, tumor cell death, and tissue repair. In the immunoactivation, you will see there is lots of T infiltrations, as well as tertiary lymphocyte aggregate, as well as plasma cells. So you can see all the other signs in the slides. You can tell your surgeons or clinicians there is a massive response from the HNE site point of view, as well as from the contrast CT point of view. So if you see the recent NCCN guidelines 2023, what we have hypothesized in 2019, the same thing has been incorporated in the NCCN guideline 2023. The Pathma Shri Awardee is advocating to go for ipilimumab in the high tumor mutation burden high-grade serous cancer, and AstraZeneca is recommending addition of bevacizumab in the high-grade serous cancer. So this is quite satisfying that what we have hypothesized long back, the same thing has been incorporated by NCCN guidelines based upon the more study. The question is, next question is that, is there any chance of relapse? Yes, if there is a brief response, after that again the tumor size goes, there is a secondary resistance. So the question is, what is the cause of that? If you can see a tumor bed, the immune cells start killing the tumor cells from outside in pattern. Okay, so there will be a residual viable tumor in the center part. So these are the clones, these are very notorious. These are immuno-edited clones. These clones, what it does, they down-regulate MSC1 expressions, because once there is no MSC expression or less MSC1 expressions, then tumor will not showcase their tumor antigens. So leads to the immunoevasions. So how to know that? We can do some.
2 minutes.
Yeah.
Last 2 minutes.
Yes, and just for some few slides. So you can do a whole exome sequencing or epigenetic integration to find out the cause. So there are multiple ways. There is downregulation MSC1. The most common is the epigenetic integration, like your DNA methylation or histone methylation and DNA acetylation, deacetylation. All these things leads to MSC1 downregulations. Then the next question is, what is the scope of artificial intelligence? As you know, being a pathologist, we used to deal with multiple complex biomarkers, starting from your Ki67 and your caspase, PD-L1 eye staining, and the CD8 topography. So it is very difficult from pathology point of view to visualize, give some precise score. What we have adopted, we have adopted the newer technology, that is artificial intelligence. So as you know, the AI has caused a major disruption in all the industries. So we have taken that into our industry. You can see we have taken deep neural network. What it caused, the deep neural network, they use multiple layers. It's like our brain. Our brain has multiple layers. So each layer capture like your pixel intensity, your optical density, size, shape, color, all these things. So there's a huge data coming over here. So what is that? This deep neural network, what it does, it captures all the data, they process in a complex mathematical modeling. So that leads to a very precise result. So for that, we need to convert our digital slides to by digital scanner. Then we can apply the artificial intelligence. You can pull out multiple information like I-score, H-score, and your density heat map, and your proportion score. All these things can be pulled out from the artificial intelligence. So same thing, we can pull out the tumor stroma classifications, monoplex and multiplex, the tumor proportions, as well as the stromal quantifications. So all this entity comes for in a response resistance quantifications. So with this, I'll finish my talk with a beautiful quote from Charles Darwin, who stated that It is not the strongest of the species that survives, not the most intelligent that survive. It is the one that is the most adaptable to change. We need to adapt newer technology, new ideas like multimodal diagnostic approach, and understand the deeper insight into tumor microenvironment, so that we can guide our clinician in a better way, so that he can go for a best possible combination to treat the cancer. This is my message to the recent fraternity, to adapt a newer technology. That's all from my side. Hope this talk resonated with you. Thank you.
Thank you so much.